Good morning, everyone. My name is Antoine Bayargent, and I'm the program coordinator here at the Ottawa branch. So I'd like to begin by recognizing that the Ottawa branch is located on the unceded territory of the Algonquin Anishinaabe Nation. We extend our respects to all First Nations, Inuit, and Métis people for their valuable past, present, and future contributions to this land and our country. So on behalf of the branch, I'm pleased to welcome you to today's session, which is titled Overview of Common Myths about Testosterone Replacement. I want to give a warm welcome to our presenters today, Mikaël Kanaan, Ph.D. student in human physiology at uOttawa, who will be doing the main presentation, and Dr. Luke Witherspoon, staff urologist at the Ottawa Civic Hospital, who will be helping answer your questions. I also want to give a special thanks to Dr. Glenn Kenny, who's the director of the Human and Environmental Physiology Research Unit at uOttawa. Glenn has been a longtime webinar presenter with the branch, and many of our members have participated in his research studies over the years. Glenn helped set up this webinar, and it wouldn't have been possible without him. So a big thank you to Glenn and his team. I also want to give a special welcome here to anyone who is not yet a member of the association. So we hope that these webinars will inspire you to join us. And to our existing members, we hope that these webinars will encourage you to maintain your membership with us. I also want to mention that closed captions are available in both French and English for this presentation. So to access this feature, you can click on the closed captions button at the bottom of your screen on the Zoom toolbar. And to translate to French, you can click on the little arrow next to the closed caption button and select the translate option. Finally, if you have any questions for our presenters throughout the presentation or afterwards, please type them into the Q&A box and they'll be able to answer them after they're done the main presentation. So that's all from me. So I'll pass it over to our presenters. Thank you, everyone.
Okay, thank you, Antoine, for the introduction. Welcome, everyone. I'm happy to be here today and present on testosterone replacement therapy. More specifically, we will be addressing the common myths around testosterone therapy, and I will be presenting alongside Dr. Luke Witherspoon. So Dr. Witherspoon is on my thesis committee. Like Antoine said, he's a urologist. He's here in Ottawa at the Civic Center. So I'm thrilled to have him on, and he will be able to take more specific questions at the end of the presentation. As for me, I'm currently a PhD student in physiology at the University of Ottawa. I've been doing some work with Dr. Glenn Kenny for the past year and a half. We've done some studies on testosterone, or we just completed one actually. And part of my thesis is devoted to understanding the physiological effect of testosterone therapy. So I'm very happy to be here, and let's begin with the presentation. So if you are interested in testosterone therapy, it is important to understand what testosterone actually is. So testosterone is a steroid hormone. The word steroid here just refers to the molecular structure of the compound, which you can see at the bottom of the screen here. It is synthesized from cholesterol by the testes, and a small proportion will be made by the adrenal cortex, so glands that sit on top of your kidneys. Its main role is to develop and maintain male sexual characteristics. So those will be the development of sexual organs, facial features, tonality of the voice, body hair, and so on. For healthy individuals, the daily rate of production will be about 3 to 7 milligrams. We'll get into the more specific ranges in a few slides, but that's about how much testosterone you would produce per day if you're otherwise healthy. So testosterone has other functions. It's not just a hormone that has sexual functions. The obvious one, if you look at the top left, is its effect on skeletal muscle. So testosterone is a powerful stimulator of muscle growth. It increases muscle protein synthesis, and it can increase muscle strength. It also has potent effect on your nervous system. So if you just look down the nerve cell here, what it does in the nervous system is it facilitates the transmission of information, and it can also have important cognitive benefit as one ages. Another effect that's not really discussed is its effect on adipose tissue, so on your fat mass. Contrary to muscle in fat cells, it actually causes them to shrink, so it increases the loss of fat mass. And if you look at studies with testosterone therapy, one of the common things you'll see is that folks lose a lot of body fat. So that's an important feature. Another one is it strengthens your immune system. So it does so by increasing the maturation of T cells, so your immune system becomes more robust. It also has potent effects on your bones. So in bones, it's like a double positive because it increases bone mineral density, but it also prevents the breakdown of bone cells. So it's very important in the mitigation of osteoporosis, especially as we age. Another important feature is its effect on the cardiovascular system, more specifically the blood. So what it does here is it increases hematocrit, so it increases your red blood cell count, and it allows you to carry more oxygen around your body. However, there's a caveat. If that gets too high, it can cause a problem. You may have heard of cyclists who do blood doping, and their blood becomes very viscous. So that's an effect of hematocrit. So as long as it stays within range, it can be seen as a positive. So those are the main functions of testosterone that you can expect if you undergo therapy. So what if you have low testosterone levels? Low testosterone levels is known as hypogonadism and is diagnosed when your blood levels are below 11 nanomoles per liter. So that's a given concentration. The normal range is 11 to 30. So it's as simple as getting blood work done. You can check your levels. And hypogonadism affects about 10% of men aged 50 to 59 and about 20% of men aged 60 to 69. And this is worldwide. So it's not a negligible thing. It's a very important condition that we should do more research on. Some of the symptoms related to hypogonadism include reduced sexual desire and activity, erectile dysfunction, lack of energy and motivation, reduced physical strength, and loss of muscle mass, and even increases in fat mass. So if you have some of those symptoms, it may be a good idea to discuss with your physician and maybe get your blood levels checked. So what are the risk factors for hypogonadism? I listed a few here. The most important one, at least that I've seen in the literature, is type 2 diabetes. So if you have a type 2 diabetes diagnosis, it is a good idea to get your testosterone levels checked. You may want to check with your physician, but that is a big risk factor. Another one is metabolic syndrome. So metabolic syndrome is usually the combination of different suboptimal health variables, if you will. So I gave an example here, high fasting blood glucose with high blood pressure and a large or big waist circumference, so over 102 centimeters, would be considered as metabolic syndrome, and that is an important risk factor for the onset of hypogonadism as well. Another one is obesity, specifically adiposity. So here I'm presenting waist-corrected body mass index. So if your waist-corrected body mass index is higher or equal to 34.5, you would be at a high risk of having hypogonadism. The reason why adiposity is important to mention here is you could be very, very muscular, so you would have a high BMI, but you would not necessarily be at risk of having hypogonadism. If you recall movies in the 70s and 80s with Arnold Schwarzenegger, he was very, very big, very muscular, but he had very little body fat. So he was probably not at risk of hypogonadism, even though he was probably using exogenous drug. But the point being is that adiposity is a risk factor itself. Another one is cancer, and this is any type. The issue with cancer, sadly, is that it's a double negative here because cancer itself is associated with hypogonadism, but the treatments as well. So they can render you hypogonadal chemo, for example. So sadly, with cancer, we have to be cautious. Sedentary lifestyle is also a big one, and this is one I will emphasize throughout the presentation, but we have to remain active as we age. It can help us mitigate the risk for hypogonadism. So if you undergo therapy, what are the modes of administration? There are multiple modes here. I present the most common. So the first one is intramuscular injection. So that would be drawing the testosterone in a needle and getting the injection in a given muscle. On the picture here, they do the deltoid, so the shoulder muscle, but it can be done in other muscle groups as well. However, I'm pretty certain physicians usually inject in the deltoid. The other one is a topical gel, so you would apply the cream or the gel on the surface of the skin. This one is less invasive. However, if you look at the literature, it's also slightly less potent. So it becomes a question of preference, but those are the main modes of administration. So now we move on to our myths. The first myth that I wanted to discuss is that testosterone may lead to benign prostate growth and increased urinary retention. Now, this stems from the fact that prostate growth itself may increase urinary retention, and some believe that testosterone will amplify that. However, if we look at the literature and what has been done, this does not seem to be the case. So here I'm presenting a randomized controlled trial where they had hypogonadal men undergo testosterone therapy. They did that for 12 months, and they gave them 250 milligrams of testosterone every 4 weeks. And what they found after the study was that the maximal flow rate, which is MFR here on the slide, increased by 30%. So this means that the rate or the speed at which the participants were able to urinate increased. So urination was facilitated by testosterone. In addition to that, voided volume increased by 12%. So the participant ended up having less urinary retention by the end of the study. And the mechanism here may be that testosterone increases the strength of urinary muscles and can also increase bladder contractility. So all these put together would facilitate urination. So this is our first myth. The second myth is somewhat related, and is that testosterone increases the risk for prostate cancer. This stems back from research done in the 1940s, where researchers gave testosterone to men who had prostate cancer. And what they saw is that the prostate cancer got worse. And when they completely inhibited the man's own production of testosterone, they saw that the cancer was doing better. It was more like fading away, if you will. However, there is a difference between testosterone fueling already existing cancer and increasing your risk. If you don't have cancer, it is unlikely that your risk will be elevated to develop prostate cancer. In fact, we have good data here suggesting that claim. So in that study, they gave 150 milligrams of testosterone to hypogonadal men every 2 weeks. They did that for 6 months. And what they found after the study was that 2 men developed cancer in the testosterone group versus 4 in the placebo group by the end of the intervention. So these men probably developed cancer because they were already at risk. But based on that evidence, we cannot imply cause and effect. It doesn't seem like the development of cancer was caused by the testosterone therapy. Now we move on to the third myth. This is one that I hear a lot, is that testosterone increases the risk for cardiovascular events. This stems from the abuse of steroids in the bodybuilding world, where you will see young individuals have a cardiovascular events because they use these drugs. But we have to distinguish between a supraphysiological dose of testosterone and a therapeutic dose. They're not the same, and they cannot really be compared. As a matter of fact, if you look at the literature on testosterone therapy, it doesn't seem like testosterone increases your risk of having a cardiovascular event. So here I'm presenting a meta-analysis. A meta-analysis is a study that puts together all the data that has been done on a given topic. So here it's testosterone and cardiovascular risk. And of the 91 studies included in that paper, 32 studies reported cardiac events. However, none of those studies were able to find an association between testosterone and the cardiac events. So the cardiac events that occurred in those studies were unrelated to the use of testosterone. However, as I mentioned, your risk may be elevated if the dose is very high. The authors here, they propose a dose that's higher than 100 milligrams per week. It's unlikely that you would get such a high dose. And just to give you an idea, some bodybuilders may use upward of 500 milligrams per week. So it's a very, very high dose. but at therapeutic dosages, it would be less than 100. Another study that I wanted to present regarding testosterone and its effect on the cardiovascular system is a study that has been done on men who were on testosterone therapy. They had to undergo cardiac surgery. And what the authors looked at is the onset of a cardiovascular event after the surgery. So they wanted to see if testosterone predisposes you to a cardiac event after you undergo surgery. And they compared them to a group of men who were not on therapy. And what they found is no association between testosterone and post-surgery cardiac events. As a matter of fact, testosterone may actually facilitate recovery from surgery because surgeries are very invasive. And what you'll find is folks lose lean body mass, and that's not a good thing. Testosterone can prevent that, and it can facilitate recovery in those regards. The last study I want to discuss regarding cardiovascular safety and testosterone therapy is a study that was recently published. This is the biggest randomized control trial they've done on testosterone therapy and cardiovascular safety. They included over 5,000 men, the average age about 63 years old. And what's interesting here is that all the men who took part in this study were at risk of a cardiovascular event. So they were cardiac patients. They were randomized into two groups. So half of the men were treated with testosterone, the other half with a placebo, so like a testosterone mimic. The average length of the therapy was about 22 weeks. And in that study, they used the androgel. So if you recall the mode of administration, it was the cream that you apply on the surface of the skin. They did that for about 22 weeks because the goal of that study was to bring the participant back to normal levels. So back to the 12 to 25 nanomoles per liter range. Once the participants got there, they discontinued the therapy. So what they found, they did find major cardiac events occurred. However, if you look at the split, it's 7% for the testosterone group and 7% for the placebo. So again, we cannot really imply cause and effect here. A major cardiac event in that study was a heart attack or stroke or something that necessitated direct hospitalization. They also found minor cardiac events in both groups, about 45%. Again, this may seem high, but we have to keep in mind that the patients were already at risk of a cardiovascular event. A minor event here could have been anywhere from a slight change in the ECG reading or palpitation, arrhythmias, and so on. One thing to note here is that individuals who received the testosterone had a higher onset of non-fatal arrhythmias. They also had a higher onset of atrial fibrillation, and they also had more kidney injuries. So if you're already at risk of an event, then maybe it's best to rethink or at least discuss with your physician before you embark on testosterone therapy. But if you're otherwise healthy, it doesn't seem like testosterone will aggravate or predispose you to having a cardiac event. So just to summarize for the cardiovascular here, your risk will occur if your endogenous levels get very, very elevated. So what we want to avoid is the extremes. If you're too low on testosterone, your risk will actually be higher, and there's good data to support this. But if your levels are very, very elevated, that's also not good. So we want to maintain in range, within the range. And the last thing I want to mention here is that age itself is a risk factor for cardiovascular events, but aging is associated with lower testosterone. So again, I'm not sure we can imply cause and effect that testosterone will predispose you to a cardiac event. Now we move on to myth number 4. This is another interesting one. Testosterone predisposes individuals to aggressive and impulsive behaviors. So you can see Mike Tyson here on the slide. This is actually a myth. What testosterone does is that it amplifies a certain personality trait. So if you're someone who's very driven, then testosterone will amplify this. If you're joyful, then maybe testosterone will amplify this. If you're impulsive, then yes, maybe it can amplify that as well. But if you look at the literature, it's only at very, very high dosages that people become more aggressive. We're talking 5 to 6 times the normal dose. So think again like bodybuilder dose. This is not what you would get if you undergo therapy. Testosterone actually has an antidepressive effects, and The interesting thing here is that it has been shown to have that effect in both men and women. It's not just in men. So the reason for this may be because of its relationship with dopamine. So dopamine is a neuromodulator, and it works tightly with testosterone. It's associated with motivation and reward. So again, the behavior aggressiveness myth is pretty much debunked. Myth number 5. This is my favorite one of all, because this is the one I hear the most in my practice, is that testosterone will turn me into a superhero and fix all my health issues. So testosterone will help with quality of life. It will help with vitality. However, it's within reason. No one's going to turn into Ben Johnson overnight if you undergo testosterone therapy. It will increase muscle mass. It will reduce fat mass, but it's within reason. Same thing with physical strength. It may increase your strength, your work capacity, your endurance, and so on. But again, it's within reason. One thing that testosterone does that is very interesting is that it helps with glucose regulation, and it does so directly at the level of the cell, but it also does so indirectly, and does so by reducing your fat mass and increasing your muscle mass. So by changing your body composition, it has an indirect effect on glucose regulation, and that is important. So the point here is that lifestyle changes are important. Testosterone will help, but you have to remain active. It's not a crutch. You have to stay active as you age. So potential risk, there's a few that are listed here. The first one is breast sensitivity. It's called a gynecomastia. This occurs because in men, we make estrogen by converting testosterone to estrogen, and estrogen causes the deposition of fat in breast tissue. So if that occurs, it can cause sensitivity to the breast. There's different ways to mitigate that. There are certain drugs that do that, but you want to make sure that it's treated, because if it gets out of hand, you have to get surgery for this. So that's an important one to consider. Another one, like I mentioned at the beginning, is increased hematocrit. So this is the increase in your red blood cell count. If that gets too high, your blood becomes viscous. That's not a good thing. It can cause joint pain and headaches. So if you're on therapy, you have to monitor your hematocrit. Another one is testicular atrophy. So this is just a side effect of using exogenous testosterone. If you undergo therapy, it's likely for life. So it's a lifelong commitment. So it's not something you can do just for a couple months. You could do it for a couple months, but the recovery is pretty harsh. So if you go on it, it's better to stay for life. And the last one is infertility. So if anyone wants children, it's not a good idea to undergo testosterone therapy or to use any other exogenous sex hormones. Frequently asked questions before we get into the more specific. Is it random screening? No. So this means that you have to discuss with your physician, and you have to request basically a blood work. So it's targeted screening in that case. What is tested for is morning testosterone. So like I said, they will check if you're within the range. If you're not within the range, they will discuss with you. If you have symptoms and you want to embark, then you may get a prescription. Will testosterone increase longevity? Not necessarily, unless you have like sarcopenia or a certain condition. Testosterone may help you become more mobile and more active, but otherwise it will increase vitality, but not necessarily increase your lifespan. If you've had prostate cancer, can you go on testosterone therapy? This is case by case. Some people who've had prostate cancer may be fine with testosterone therapy. Others may be responding negatively. So this is something you have to check with your physician. So before we move on to the questions, I just want to present some of the research we do, or some of the research I do with Dr. Witherspoon, Dr. Glenn Kenny. The first project I want to discuss is my main thesis project. This is going to be the biggest randomized controlled trial with testosterone therapy and lifestyle changes. So it includes exercise and diet. I've done a similar study before with athletes, but I want to do the same procedure with hypogonadal men. So this would be an 8 to 12 week study. It includes a DEXA scan, so full body composition analysis, fitness testing, so VO2 max, strength testing, blood work. Like I said, we make a personalized nutritional intervention, personalized exercise plan. So this is expected to start during the spring of 2026. And I will be looking for middle-aged or older men that are looking to start therapy or not. I want to compare men on therapy versus men who are not on therapy at the time of the study. So stay tuned for this. And if you are interested, feel free to reach out. The second study I want to discuss is a study that I want to do with Dr. Glenn Kenny. He has the biggest thermophysiology lab in the world. This is the direct calorimeter. So this chamber, we cannot see on the picture here, but there are actually pedals at the bottom. So this is an ergo cycle. You can exercise on this. And this calorimeter allows to directly measure the heat that your body dissipates. So what we want to do here is we want to see, does testosterone has an effect on heat dissipation? Does it help you get rid of heat? So as we age, our ability to dissipate heat is worse. So if testosterone can help with that, that's another benefit of the therapy. It would mitigate the risk for heat-related illness or events. This is just a one-time visit at the lab. It includes a 12-lead ECG, a VO2 max test, and even a body composition test. We do all sorts of blood. We look at all sorts of blood markers. So the value of doing a study like this for the testing is about over $600. So if you are interested and you are on testosterone therapy, please reach out to us. It's about a 90-minute cycling protocol in the heat, about 40 degrees. That's expected to start in the spring of 2026 as well. And the last project I want to discuss, this is a study in cell culture. So all we need is a blood donation for this, one-time visit at the lab. What we want to see here is the effects of the drug tadalafil on cellular function. So this is the drug Cialis. Maybe some of you are using it right now. Tadalafil has effects on multiple organ systems, including your skeletal muscle, your fat cells, your brain, your heart. But basically what we want to do here is draw blood, isolate the cells, and then treat them with the drug tadalafil, and we want to see how it impacts cellular function. So this is an important study because it's a popular drug and it may have effects that we don't know about. So again, this is a one-time visit. All we need is a blood donation at the lab. So your help will be very appreciated. You can learn more from us on our website. So this is hepru.ca. Just go on your Google search bar, type in hepru.ca, and you will have all the information about our research, all the projects that we're doing. We have a newsletter. So just type in hepru.ca and you will be redirected to our website. And you can contact us directly from the website. And lastly, I would like to give a special thanks to Dr. Glenn Kenny. I've been working with him for the past year or so. It's a privilege to work in his lab. And like I said, it's the biggest thermophysiology lab in the world. I've learned a lot. So I'm looking forward for the next few projects that we will be doing together. And I also want to give a special thanks to Dr. Witherspoon. He's been mentoring me for the past year and a half as well. We've done some work on a bladder cancer patient and ICU patients with testosterone. So I'm looking forward for the next few projects that we will do together. And lastly, I want to give a shout out to one of my colleagues who's on the call. It's Dr. Jeremy McCormick. He's the one that has taught me all the in vitro stuff in Glenn's lab and Dr. Kenny's lab. So big thanks to Jeremy. And now we can take more specific questions for Dr. Witherspoon. Thank you all for your attention.
Thank you, Mikaël. So we do have some questions in the Q&A, and we already have some questions that Dr. Witherspoon has answered in the chat already. So
I see the chat, so
Oh, just
I
put that Q&A down there and you can look. So
yeah,
yeah.
I'll be reading out the questions out loud for you two, and
okay.
you can just give your answers. So our first question is, I think you've already answered, but just if someone was interested in volunteering in those projects that you mentioned at the end, they would just go on the website and contact you?
Yeah, they can do that. So by contacting us directly, we can enroll them. Sometimes we have posters that we put up on the website as well, so they can register directly. So yeah, the best way would be through the website.
Perfect.
Just one thing, Antoine, they can also they can all email me directly as well, as Mikaël said. So anybody that is interested in asking for more info about the research we do, gkenny, so GKENNY at uOttawa.ca, and I will put that on the chat. Sorry to interrupt, guys.
Thank you, Glenn. That's perfect. And I just want to let everyone know that the link to their website and Dr. Kenny's email will be included in the follow-up email that will be sent later today. So another question is, if one were to start treatment, what is the average cost per month?
So that's a good question. That varies widely because there's a couple different formulations of testosterone. So right now, the sort of mainstream ones would be a gel called Androgel. It's the only manufacturer of that right now. You typically take a little sachet once or twice a day that you'll rub on your arms or your thighs. If you have drug coverage, almost all of these would be fully covered because it's not something that is, off-label or something like that. So typically it's pretty cheap. If you're paying fully out of pocket, it's probably less than $120 or $150 per month, regardless of the formulation you use. The other two formulations that exist right now are a nasal, they say spray, but it's more of a gel actually that you kind of have to snort in your nose. And then a couple different types of injections, which are all basically the same thing, just different sort of formulations of testosterone. The big thing for guys to know who are thinking about or maybe testing with low testosterone, thinking of starting is, unfortunately, for the last maybe even 5 to 10 years, there's been issues with supply of testosterone, meaning frequently we will get notifications both across North America, even Europe, that there are back orders basically. And that's one of the problems is when you start testosterone, and especially in guys who have started it for maybe not clear reasons. So thinking I've convinced a physician to give me a prescription even though my levels maybe weren't low, or taking it just buying it online or something like that without a prescription. Once you start it, it will shut off your body's natural production. And so one of the things I talk a lot about with patients who are considering this, especially if they're in kind of a gray area of requiring it, is you're now going to be at the mercy basically of the industry producing it, because your body won't make any of its own testosterone. So things like cost and availability, this is a kind of a rare area in medicine where it actually makes a big difference, right? So right now, it's changing a little bit, but for maybe the last 3 or 4 months, injectables have been unavailable. Like we can't get them, but all the different manufacturers aren't producing it or having issues producing it. So we've had to switch, hundreds of guys over to Androgel. And then if that was to go off the market, even the nasal spray has been having problems having it be available. And we're close sometimes to finding scenarios where if we lose all available formulations, you're going to have a lot of guys who aren't going to feel very well. So it's actually one of the risks I talk about is if you go on this, it's theoretically a lifelong medication, and it's one that you can have your life upended a bit if you can't get access to it.
Thank you. Our next question here, you noted intramuscular injection. Some recent studies have indicated that sub-Q is more effective and with lower hematocrit implications. Do you have an opinion on this?
Yeah, so sub-Q, I mean, I'm surprised. I don't actually, I'm aware of a study looking at sub-Q for testosterone. One of the reasons we don't do subcutaneous administration of testosterone is that you're depositing it into adipose tissue, and adipose tissue, like fat tissue, Even in a very lean person, subcutaneous, that's basically where you're going to be injecting it. We all have a thin layer of fat under our skin. Theoretically would break it down a bit faster. It wouldn't be able to distribute it as nicely as intramuscular. Similarly, the hematocrit implications have less to do. I'm surprised a study would find that as long as it's normalizing your testosterone or raising your testosterone, that's really where the hematocrit levels seem to come from. If you're injecting the same thing, and injectable testosterone, they certainly affect hematocrit levels higher. The intranasal version and even androgel tend to not raise hematocrit as much. That is thought to be the result of the slower, more physiologic release that people are getting when they're taking. So the nasal one you take 2 or 3 times a day, so you're not getting this massive spike that an injectable would give you. And because of that, that's what the theory behind why the hematocrit levels aren't raised as much. We're also starting to understand, to be honest, that hematocrit levels probably are less of a concern than we think. We used to be very, very concerned about them. And now, to be honest, we tolerate even a relatively high hematocrit, as long as someone's not symptomatic, like muscle cramps, headaches, etc., before we tell someone to go to blood donation or to drop their hematocrit or to reduce their dose.
Perfect. Our next question, would my prostatectomy adversely affect T therapy?
Yeah, so it depends. So prostatectomy for people who maybe don't know what that would mean, that would be having your prostate removed, generally for prostate cancer, like 99.9% of the time. And so it depends. If you are fresh after your prostatectomy, then your oncologist is going to be very uncomfortable putting you on testosterone. That because they're worried that if there's some cancer cells that are still there. So this might be a cancer cell that is literally in single digit, numbers. That might not be a problem for a person for 10 or 15 years, right? It might not be something that individual ever has to deal with in terms of a cancer recurrence. This is purely theoretical, but the worry is if you give that person testosterone, could you potentially, cause that cell to proliferate at a higher rate and suddenly become an issue? That is controversial because, as Mikaël even hinted at, basically every study that's looked at this has found that if you are hypogonadal, meaning low testosterone, after prostate cancer, that actually seems to be potentially higher risk for having a recurrence of prostate cancer than otherwise. However, we are still stuck in, because no one's done full randomized controlled trials to prove that. This is all retrospective data. And oncologists don't tend to change their practice until they have very concrete data. And they are still basing their opinions on the fact that the mainstay of metastatic prostate cancer treatment, so when cancer has spread outside the prostate, is androgen deprivation. So they give chemical castration, so the opposite of testosterone. They're giving guys drugs to drop their testosterone to 0. And so in those settings, because that works so well to slow prostate cancer, we continue to have this worry that normal testosterone levels could, or giving someone testosterone to get them to a normal testosterone level could increase the risk of cancer. However, like I said, most of these initial studies that are starting to get done by some, to be honest, brave patients and physicians who are saying, well, we think this is probably safe, are indicating that it likely is safe. So maybe 10 years from now, we'll have a concrete answer of, yep, you could go on it right away if your PSA is undetectable after surgery. It's not going to change the risk for you. But I suspect your oncologist, depending on how close you are to your surgery, would not be particularly excited about you going on it. Most guys will come see us maybe around 2 years afterwards if their PSA is undetectable. And then oncologists, radiation oncologists, whoever's treating you for prostate cancer, is pretty happy with you getting normalized levels because they say, your risk of recurrence is so low that this can't possibly make you have a higher risk.
Thank you. Our next question, can you say a few words about aromatase aromatization,
yeah.
and
So
relationship with
I think what
TRT.
that question's getting at is so all of us convert our testosterone, or one of the main places we convert our testosterone is in our fat tissue, and we convert it into estrogen. And that's how we get rid of testosterone. So it might sound counterintuitive, but if I give someone testosterone, I guarantee I will raise their estrogen level. And so that's an important concept for two reasons. One, uh, we have rising obesity rates in Canada, and the more adipose or fat tissue you have on your body, the more your body will eat up testosterone because your body's going to have more of these fat cells that are able to aromatize, that's what that term means, aromatize testosterone into estrogen. And so the more fat you have, technically the lower your testosterone would probably be and higher your estrogen would be. So when guys say, can I naturally try to improve my testosterone if they're overweight? We say, yeah, that there's good evidence that would say if you lose weight, you will not aromatize as much testosterone and you will naturally raise it. And I've seen that many, many times, although that's obviously very hard for anyone to lose significant amounts of weight. That takes effort and planning. The other reason we care about it is for guys on testosterone. So some of those side effects like breast development and stuff, that's happening because their estrogen levels are rising. And so that's something we monitor guys for. And again, we like everything in medicine, we change things as people get, more evidence around these. And it used to be that if your estrogen got high, we would actually give you a medication to try to stop that aromatization. So we'd actually try to stop that conversion happening in your adipose tissue, lower your estrogen, and prevent you getting those side effects. So people went out and did that for 10 years, and we figured out that actually estrogen is probably tied to things like libido more than we thought. So it wasn't just that everyone thinks testosterone is going to help with libido, and that's why when we give guys testosterone, most men will report, hey, my libido went up. Um, we think it's actually more tied potentially to the rise in estrogen that happens as well. So when we went out and knocked all these guys' estrogen levels to zero, a lot of those men were saying, whoa, what the heck's going on? My testosterone's still up, but I've lost that benefit. And so now we tolerate a high estrogen. I can't remember the last time I've swapped someone onto one of these other medications, which, to be honest, aren't the nicest medications to be on anyways. They have other side effects. To drop in estrogen, we just tolerate it as long as the guy's feeling okay. If they start developing some breast tenderness or very rarely develop actual like fat tissue deposition of like breasts, which would be very rare, that can be a big problem. Like that's something that even if you stop testosterone doesn't mean it's going away, or lower the testosterone or start one of these other drugs. Very rarely some men actually have to have like, breast reduction surgery with a plastic surgeon to remove some of that tissue. But that is very rare. That'd be a one in thousands event that a man would have to have that happen.
Okay. Given the difficulty in diagnosing clinically significant prostate cancer, the follow-up periods in the studies quoted seemed short. Do you have a comment on this?
Yeah, and that's why I think if right now you put me and an oncologist in a room and we debate, is it safe to put someone on testosterone in the setting of either low risk prostate cancer, so some guys have been diagnosed with low risk prostate cancer, they're not getting surgery or any treatment, we're just watching them. That's one group that we still don't know, is it safe or not to give testosterone. All the way up to people treated for prostate cancer, or even people who have metastatic prostate cancer who are on therapy with androgen deprivation, but who are very symptomatic from their low testosterone. And we debated based on the evidence, who is it safe to give this to? I don't think either of the groups, the oncologists or myself, or we call ourselves andrologists, would have a definitive answer for you. We would both have fairly convincing data on both sides to say why. So the oncologist would have data saying, look, if we get a testosterone to zero, we stop a lot of prostate cancer in its tracks. So of course, giving more testosterone should be worse. And on our side's argument, we would say, well, yeah, but you're not knocking every single guy's testosterone to zero. As long as someone doesn't have metastatic prostate cancer or recurrence, you don't care what their testosterone is, right? They're not screening post your prostatectomy. They're not screening you for your testosterone because they don't care. Because they probably shouldn't care. It's not something that's affecting your cancer. Meaning, a guy with a natural normal testosterone does not seem to be at any higher risk than someone who naturally is low. And in fact, like Mikaël was kind of pointing out, there are some studies that have shown that if you are hypogonadal in that setting, so you've had prostate cancer, it's been treated, and someone does screen your testosterone and it's low, you actually seem to be at potentially a higher risk of recurrence. And so we need better studies into this. And again, it unfortunately takes brave souls, both on patient sides and physician sides, because we would truly be doing something where we don't know, right? So if you took a bunch of guys who are hypogonadal and said, you're symptomatic, you have low testosterone, you have prostate cancer, let's give you testosterone and see. That study would be assessing to see if your cancer came back. So it's quite hard to recruit patients for that. And so what we end up having to deal with is patients who are so symptomatic that they've accepted that risk, and as a result they've gone on it, and then we retrospectively we look back and see, based on following them for a couple of years, did they get a recurrence? And to answer the question, which is the time frame, prostate cancer does move slow. It's not something that is like lung cancer, brain tumors and things where people's lifespans are measured in months or years. A guy with metastatic prostate cancer that's spread, the average lifespan now with current medications and things can be like 10 or 12 years. Like, it can be very long, and it's only going up because we're getting better drugs all the time. And so it's very tough to run one of these studies that would last 10 years, that would be able to accrue patients to be able to answer them. And right now there's not really one going on. So we won't get that answer definitively for at least a decade or more.
Mhm. Our next question, would more testosterone fix my gravelly voice?
That's interesting, because I have a theory. It's not a real one. It's one I've wanted to. I don't think anyone cares for this study, but I find, at least, and there's a little bit of evidence for this, that high testosterone actually does affect our vocal cords. I don't know if Mikaël, you could tell me if you agree with this. I can hear now if someone's speaking to me. I know if they're on testosterone. So, and you might imagine in my job, I will get the odd guy who for different reasons, doesn't want to tell me he's on testosterone. I mean, I see a lot of guys for infertility, so they'll be sitting, next to me with their partner, and he's infertile, and I can see from his blood work that he's you can't hide it, he's on testosterone. But I knew that from just walking in the door, chatting to him. So it's funny that if you say fix your gravelly voice, it might make it worse. I find it makes a more gravelly voice, to be honest, in guys who are on testosterone. And there is a little bit of evidence that it maybe changes some of the musculature around our vocal cords, leading to voice changes. But that's not a known thing. That's funny you say that, because it's something I've often thought about, that we all know it, but no one's really described it.
Interesting. Our next question, how good / potent is the androgel treatment?
It's fine. I think why you're probably even asking that question is I do find it's the most swapped off medication. What I mean by that is starting a guy on it, testing their levels in 3 months, and not finding that it's increased their levels significantly. I think it just has the most it's relying on a couple of things that are going to be very different from person to person. How well you get it on your body. It's like anyone who's on it, it's kind of like a thick, oily substance. It's not that easy to give yourself. So how well is your skin actually absorbing it? How diligent are you on absorbing it? How much is getting onto your, maybe you don't have time in the morning, you rub it on, put your clothes on, half of it soaks into your clothes. I hear a lot of patients who say they ruin a lot of shirts with like oil stains basically from it. Um, so I know they're not getting their dose. It also doesn't really give us a lot of ability to titrate dosing. I mean, you can try to take like a package and a half, 2 packages, that kind of thing, but it's not as discreet as something like an injectable. There is in the US available right now an oral form of testosterone, and that may be coming to Canada, or hopefully is coming to Canada. Oral has eluded us in testosterone therapy just because we clear a lot of our testosterone if you take it orally via our liver. So our bowels absorb it and it goes right to our liver before it gets to our bloodstream. And our liver is trying to do a good thing. It's trying to clear toxins. It views it kind of as not a toxin, but something to be removed, and it removes it before it gets to your bloodstream. So there are oral versions available in Canada, but any urologist or endocrinologist doesn't use them as they're so variable, like it almost never works, and it's something that can be hard on your liver sometimes. But there's a new version that apparently has been engineered to get around that and has been available in the States. So I agree, androgel is the least invasive thing. There's no injections, it's easy to put on, etc. But it does kind of not meet many patients' expectations.
Thank you. This next question, is there any evidence to support claims that red light can increase testosterone levels?
Yeah, that's a very timely thing, because there's, for anyone who doesn't know, sort of, you've probably been, if you're spending any time online, pushed ads for red light therapy for everything from depression to libido to hair regrowth. Red light therapy, there's very little data on it, so certainly no one has done any good studies, but we're actually in the process of publishing a review on some of these kind of, whatever you want to call them, alternative medicine therapies. Red light therapy, as compared to things like other sort of hot button things like saunas and ice baths and stuff, which don't seem to really do very much, at least from a long-term perspective. Red light therapy seem to have some of the best initial evidence for things like increasing libido. No one's really looked at testosterone levels, but they have looked at erections and libido, and it does seem to have a response. Is it massive? Probably not, but it's extraordinarily safe to use, and the devices themselves are not particularly expensive to even get a good one. So it's something that if you want to make part of your, daily regime, I think it's doing zero harm. And most evidence that has been looked at for it says it does seem to be somewhat helpful for raising the symptoms. No one's done some of the biochemical analysis to see, like, are we seeing testosterone go up? But believe it or not, I was very surprised actually at when we did a meta-analysis of some of these, that red light seemed to come up as the most effective in the trials that have been published.
Perfect. And our next two questions kind of are very similar,
Yeah.
asking about natural ways to maybe increase testosterone instead of the medicines and the gels and the
Yep.
injections.
So, very common question. So you kind of have to thread the needle a little bit in terms of drastic things are not going to help your body. So if you do like extreme weight loss, extreme exercise, that'll probably drop your testosterone because your body's stressed. It's not wanting to build it. So this goes back to the same idea that, to be honest, dietitians and physiotherapists and everyone have been touting, not specifically because of testosterone therapy, but just because of safety, to slowly make changes. So you shouldn't be doing rapid weight loss. You should be losing half a pound a week, something like that. And exercise, you probably do not need to do more than 30 minutes a day of moderate intensity exercise. We know in some extreme endurance athletes, etc., that low testosterone is a problem because their body gets so stressed from them just continually, stressing out the body in terms of extreme exercise, that they'll drop that. And same thing, if you drop extreme weight fast, like you go onto a starvation diet or some of these like carnivore diets that have been promoted recently, where it's like, I'm just going to eat meat all day, nothing else, and very low calorie, probably actually does the opposite. And there is emerging evidence that that is the case, especially from a diet perspective, that it does not help your testosterone. So slow weight loss, moderate intensity exercise, and good sleep. Good sleep seems to make a difference. Having an adequate amount of sleep, 6 to 8 hours, something like that, not more, not less, is probably something that can help you naturally raise it.
Great. Good to know. We have a question here. If you have a prostate nodule, should you avoid testosterone treatment?
It's a Good question. It kind of depends. If that prostate nodule has been fully evaluated, meaning someone's done an MRI or a biopsy evidence that it's nothing, then yeah, that's fine. You shouldn't be at any increased risk. If you have by prostate nodule, sometimes if someone does a digital rectal examination, that's like the finger test where a physician feels your prostate, if they have just commented like, hey, you have a lumpy prostate, like that's not an uncommon thing, but your PSA is fine. They're not worried that you have anything. Then testosterone would similarly be okay. And anyone who goes on testosterone is going to get or should get, if they're following guideline therapy, a PSA check at 3 months, a PSA check at 6 months, and then every year forever, which, to be honest, males should be getting anyways, at least until the age of 70 or 75, like a PSA check for prostate cancer. That's our blood test screening for prostate cancer. So, have I detected prostate cancers where we give testosterone, their PSA goes up, and then we do more investigations? Yep, like that does happen, and that's why we are screening it. And so, if you're worried about it, it would just make sure that if you go on testosterone, to get your PSA checked and investigate everything if a abnormal value comes up.
Could a drop in T levels result in andropause type symptoms, even for someone whose T levels are presently within the normal range?
Yeah. So this is, probably one of the things I spend the most time talking with patients about because testosterone's become so discussed in society that we under every male is aware of it, and it's something that everyone wants to get tested and to attribute a lot of their symptoms to. So first of all, I mean, it's extremely common in just being a human being that you have periods where you're tired or your mood is down, you don't have energy to exercise, etc. It's pretty normal as males age that it's harder for us to put on muscle mass if we're working out in a gym, etc. And it's not specifically always tied to testosterone. So most, the way at least I practice, and I would hope that most urologists and endocrinologists practice would be if you have a good total testosterone, like smack in the middle, then it's something where we would not recommend therapy. There is a gray area, which is basically where if someone has a level, as Mikaël pointed out, we want a total testosterone between about 11, just below 11, but 11, let's say, just to make it easy number, and maybe below about 25 to 30. Higher doesn't specifically necessarily matter if you're naturally producing it, but nonetheless, as long as it's around there. If we have someone who's hovering around 12, maybe even 13, and they're very symptomatic, that's where we can actually use some of these other forms of testosterone. We can test like free testosterone to look at it and see is that other types of testosterone, it's the same testosterone, but different ways it's bound in our bloodstream, is that level also normal? And if that level is also normal, then we have a discussion with the patient. Do you want to, we don't think you'd benefit from this. But I have a lot of guys who are, they'll be 16 and they're like, well, that's lower than the upper range, so why shouldn't we just try some? And that comes back to some of those issues of, well, look at if we put you on it, it's going to stop your natural production. So that if you get you don't like the reaction, you start having issues where other blood values get abnormal, like your hematocrit, like how thick your blood is. You're having to go do blood donations every month. The pharmacy runs out of testosterone. Now you're really feeling, crummy because we've dropped you to zero. Those can really impact your life. So going on a medication like that is a big choice. If you look at it on the, from a female perspective, let's say in the 90s, it was all the rage to put females on hormonal replacement for menopausal symptoms. So almost every woman out there, because every woman will go through menopause in their life, were offered, hormonal therapy. Then we realized that is a horrible approach, and a lot of different cancers got picked up that were hormonally sensitive, and a lot of women got cancers because of that approach. And that scared away almost every female from going on hormonal therapy to the point now that there are probably many women out there who would benefit with safe administration of this hormonal therapy, and don't want to go on it because of what they've heard. Versus males, we haven't had that widespread adoption of testosterone yet, where like, you know, not a majority, but a huge chunk of male society has gone on testosterone. So there may be other things out there that we haven't picked up yet. So that's why I counsel guys, if you're normal, don't mess around with the biology of your body. I don't think your, you know, tiredness, etc., is going to be fully reversed by taking this exogenous hormone that's going to shut down basically your own natural production.
Good to know. So we are a bit past 11, so I think we're gonna have to wrap up the questions here. I think we got to most of them. I know there's still some in the chat, but we will be you will be able to send questions via the follow-up email. We'll be including also the website that Mikaël mentioned for the studies. And so I think we're good to finish it off here. So I just have some closing remarks for everyone. So thank you everyone for your participation in today's webinar. And a big thank you to Mikaël and Dr. Witherspoon for their great knowledge, their presentation, answering all those questions. I know our members learned a lot and got a lot from this. And if you couldn't tune into the whole thing, we did record today's presentation, and the recording will be sent to you in the follow-up email, along with that other contact information. And finally, I want to remind everyone that you can invite non-members to attend these webinars and try us out as a guest. So please visit the Ottawa branch website at nafrottawa.com to check out our upcoming webinars. So thank you, everyone. Thank you to our presenters, and we'll see you at our next webinar. Bye-bye.